So I'm just filling in Dr. Narendran's shoes, and I apologize for that, but he's a little busy in the conference. So on his behalf, I'll be talking about Rop type 1, the clinical features and the management. So again, this slide shows the natural history and the onset of screening. So at whatever birth weight a child is born, the ROP usually starts developing from 32 to 34 post-conceptional age. So it's prudent to start screening at 31 weeks post-conceptional age. And as the disease progresses at around 36 to 38 weeks, around at a mean of 37 weeks is where the treatable ROP is going to appear, and this is where it's prudent to do your examination in this window period, because after that, if it's going to regress, it's going to regress. At this point, if it starts progressing, then by 42 weeks, it will go for blindness. So the screening guidelines in the West is 31 weeks post-conceptional age, which makes sense, or 4 weeks after birth, whichever is later. But for India, it is termed as earlier. And why do we have to be different from the West? I mean, do we see a different set of babies? Are we genetically different? But it's this, that it's because of just the excessive unblended oxygen which we give. So it is, for us, we see a little early because of a little more oxygenation that pediatrician gives. And when the child is out of the oxygen, the disease comes earlier. So it is a little different for us, so we have to start screening a little earlier, and the easiest way would be to screen all the babies by 30 days of life. So again, just going back, this was the previous cutoff for treatment, the threshold disease, which was defined by the cryo-ROP study, and it was defined as a stage 3 in zone 1 or zone 2, having more than 5 continuous or 8 cumulative clock hours with plus disease. So this was given by the cryo-ROP study in '88. And of course, the ET-ROP, it proved that it is, I mean, we all knew that instead of waiting for threshold, it is better to treat at pre-threshold, and they divided the ET-ROP in pre-threshold into type 1, the high risk, and the type 2. The type 2 has already been wonderfully covered by Dr. Suchita. So what is the type 1? It's, if you see a zone 1 disease, any stage, when I'm talking about any stage, is stage 1, stage 2, stage 3, which you can prevent blindness with plus, it's a type 1 ROP. A zone 1, stage 3, even without plus, falls in this net, and a zone 2, stage 2 or 3 with plus is again type 1 ROP. So this reduces the confusion of number of clock hours, the continuous and non-continuous clock hours, so it has made things a little bit easier. And type 2 was already been mentioned by the previous speaker, that there is no plus in zone 1 with stage 1, stage 2, or in zone 2, stage 3 without plus. This just requires observation, and if it only progresses to type 1, then only you do the treatment. So this table shows an easier way of when will you treat and when not, the type 1 and the type 2. So these are the red ones, which are the type 1 ROP. So zone 1, no plus, only stage 3. Zone 1 with plus, any stage, you do the treatment. So these are the type 1. Zone 2, no plus, no treatment. And zone 2 plus, only the stage 2, stage 3 require treatment. So coming to the management, so how do we manage? So if we see a zone 2, if it's a stage 2 or 3, then obviously the laser is the first thing, and it should be done because it is well away from the fovea, unless what the audience was asking about the notch coming inside. So it's very prudent to see that it's exactly what you're talking is zone 2 and only zone 2. But if you see irrespective, I mean, there are a lot of disease will be in zone 2, but you will see in one clock hour area temporarily it's dipping into zone 1, so that changes the management protocols a little bit. So like I said in my previous talk, that for AP-ROP now anti-VEGF is taking over laser. So that would be the preferred thing, but it should be taken with a pinch of salt. You cannot just give it alters the natural history of the disease. The slide which I showed you earlier, that the threshold disease will come at 37 weeks. If you give anti-VEGF, it is pushed to 60 weeks or 80 weeks. So there is a chance of recurrence, and you have to just see the risk and the benefit. And now in a stage 1, in zone 1, 2 or 3, laser or anti-VEGF, it's debatable. So if it's a classic stage 3, if it's well away from the fovea, laser would be still the preferred choice of treatment. So this is the video showing the laser using the diode infrared laser. And this is just to show you, although it can be done topical anesthesia, you will require emergency backup and a pediatrician anesthetist somewhere around. And this is just an infant warmer which we use called the embrace nest during the laser to keep the child warm. So you do the monitoring of the child, and this warmer, it has a wax sheet actually, which takes only half an hour to charge, and once it's charged, you just put it inside this jacket, and it maintains a temperature of 36 degrees Celsius for 4 hours. So it's a very good thing, because you want the child to be comfortable, you want the surgeon also to be comfortable, and it sometimes becomes too cold in the air conditioning to put off. So to keep both comfortable. So this is what is an ideal thing which we use here. This is used mainly for the neonatologist, by the neonatologist, to transfer a child from one NICU to the NICU, and it's a mobile thing, so it's quite handy. And the other advantage is that it wraps up the child very nicely and snugly, so there is no sort of movement, and you can really pin down the child, which you want that while doing the laser under topical anesthesia. And of course, we keep the child fasting for 2 hours, and then during the laser, we give a little bit of sucrose or 20% dextrose, 25% for the child to suck. And this is how it looks, the embrace nest. These are all one-time investment, and this can be used and reused for multiple times. The wax sheet has got a life of 1 to 1.5 years, and you might have to change, and it's not very costly. So it is quite, and we can use this in the operating room also while doing vitrectomies, and that's quite a big boon for us, because these children have to be kept warm, and the operation theaters, which are centralized ACs, can be put off for this one case. So this is really good. So this is how laser is done. And you see the aiming beam inside the retina, and you start giving grade 2 to grade 3 burns, which are near confluent, and which covers the entire avascular retina from the new vessels to the ora serrata. So it cannot be like a diabetic PRP where you do a one spot width apart. It should be near confluent, half or even less, and the entire avascular retina has to be treated in one shot, and not wait for 2 weeks and come back and do it, because that's going to progress the disease. And if both eyes are required, then both eyes have to be done simultaneously. So the advantages of laser is, of course, it's under topical anesthesia. It can be done even the OPD, but you have to have an emergency backup, and the systemic and the local complications are much less. So just to highlight that in the severe case of ROP like this, where there's a total knockout of capillary dropout, you can't do a laser in such cases. So you have to, so with the, thankfully we have the anti-VEGF. If you do a laser, and this is what could happen, that this is a case which is referred, and we don't know where the fovea is ending, and you can end up actually burning the fovea, and that will be a disastrous outcome of using this laser. So this is where the anti-VEGF has an edge over laser in such severe case of AP-ROP, and you can see post-Avastin the capillary network is growing. At 3 months the fovea is vascularized, and at this time there is no harm in giving the laser if the disease recurs. This is a short video showing the anti-VEGF injection being given. It's a routine procedure like you do in the adults, only thing the dose is 0.02. It's still debatable what will you use, but at around 1.5 millimeter from the limbus, you just go inside, inject, and come out. There's no need to do any paracentesis or anything, and if you think the cornea has become cloudy, that eye tolerates well, you need not go and do a parenthesis, because we had cases where there has been lens touch after that. And usually we prefer to give both the eyes together if it's required, but there are some people who would not to give both the eyes, they would take a 2 days gap and then give it. So in conclusion, in 1980s, the cryo was the leading mode of treatment. In 1990 to 2000, the laser replaced the cryo, and the cryo actually disappeared. And now in 2010, anti-VEGF is there. So is it going to replace the laser? We don't know. So the answer is that in the fight between the anti-VEGF and the laser, who's going to win? Is it going to replace the laser totally, or what's it going to be? So I think the verdict is that they're already falling in love with each other, and I think they're just going to get married, and they both are going to live together happily ever after, because that's the best thing which you can offer for some of these severe cases of ROP.